Hello. Welcome, everyone. We're glad to see you're all here today for our Medical Informatics Grand Rounds case presentation. These are first-year medical students presenting cases from the Massachusetts General Hospital case files. We'd like to begin with our two cases here and appreciate your attendance. One thing we do during our presentation is if you have questions, we have you write them on the cards that have been distributed and walk them down to the table for the panel discussion after the case presentation. So with no further ado, we'll begin with group number 3.
Thank you for everyone for attending. We're Group 3 presenting Case 18 from the 1998 case records of Massachusetts General Hospital. This is our team of student doctors that was involved with this case. And I'm student Dr. Robert Bowd, and I'm going to be discussing our patient's history and clinical presentation. Our patient's a 54-day-old female who was admitted to Massachusetts General Hospital for recurrent respiratory distress and failure to gain weight. Our patient was born prematurely to a 38-year-old woman who had 2 prior pregnancies, neither of which surpassing the 20th week of development. Our patient's mother was immune to rubella and negative for syphilis. The pregnancy was complicated by the mother smoking cigarettes, less than 1 pack per day, and a respiratory tract infection that was treated with erythromycin 2 weeks prior to delivery. Prenatal ultrasounds had been showing delayed fetal growth. During the 35th week of gestation, diagnostic amniocentesis revealed meconium in the amniotic fluid, and an ultrasound showed a decreased fetal heart rate, which led to an emergency cesarean section delivery, and our patient was born weighing 1.5 kilograms, which, as you can see on this chart, was 1 kilogram below the average weight for that gestational age. Our patient's APGAR score was 7 out of 10 at 1 minute and 8 out of 10 at 5 minutes. Brief supplemental oxygen was provided and no resuscitation was necessary. Our patient tested negative for cytomegalovirus and toxoplasma infection. From the time she was born, our patient was transferred between various hospitals all the way up to her admission at Massachusetts General Hospital. Lab tests from day 1 showed a low white blood cell count at 7,600 when compared with our reference ranges over here on the right, and a remarkably low lymphocyte count at 304 compared to the reference ranges. On day 4, our patient was transferred for feeding and growth, and on day 8 developed a diaper rash with no response to treatment. No thrush was observed. Lab results from day 13 showed a decreased white cell count to 2,800 and a low lymphocyte count at 308. On day 26, our patient presented with tachypnea and intercostal retractions. A chest x-ray was taken and revealed pulmonary hyperinflation, bilateral streaky opacities in a perihilar and peribronchial distribution, rib flaring at the anterior margins, seen better here on this lateral view with the widening of the intercostal margin, and bone-within-bone vertebral bodies seen in our patient's vertebral column. Interestingly, our patient's x-ray also showed the lack of a thymic shadow seen here when compared with a normal x-ray of a patient that does have a thymic shadow over here. This indicates that our patient lacked a developed thymus, which may help explain her low lymphocyte levels. Lab tests that same day showed a low white blood cell count at 2,300, which had decreased from day 13, and a low lymphocyte count of 230, also decreased from day 13. Blood specimens were obtained that day for culture, and our patient was started on an empiric antibiotic treatment with ampicillin and gentamicin. A chest x-ray taken on day 30 revealed atelectasis of the right upper lobe seen here, and the blood cultures taken 4 days previously came back positive for coagulase-negative staphylococci. Our patient was continued on ampicillin and gentamicin for an additional 11 days. 6 days later, on day 36, a chest x-ray showed improved pulmonary findings. On day 44, our patient presented with tachypnea again, just 3 days after finishing her antibiotic treatment. Physical examination showed occasional wheezing with scattered crackles bilaterally. All the physical examination results were normal. Our patient's vitals were an axillary temperature of 97.1 degrees, a pulse of 99, a tachypnic respiratory rate of 70 breaths per minute, and a blood pressure of 105/90. A chest x-ray taken that day also revealed pulmonary abnormalities. At this time, our patient weighed just 2.1 kilograms. And as you can see on this fetal growth chart, our patient was 2 standard deviations below average in weight for her age, 1 standard deviation below average for head circumference for her age, and 2 standard deviations below average in length for her age. Lab results from day 44 showed a normal white blood cell count that had increased to 12,300 and an increased lymphocyte count at 369 that still remained far below the reference range. Our patient's platelet count had also decreased below the reference range to 134,000. Our patient tested negative for chlamydia, respiratory syncytial virus, adenovirus, and influenza type A. Antibiotics clindamycin and cefuroxime, a second-generation cephalosporin, were administered, as well as albuterol via a nebulizer, which resulted in an improvement of the patient's condition. On day 47, a chest X-ray then showed improved pulmonary findings. Immunoglobulin testing revealed low levels of IgG and IgM antibodies and normal levels of IgA and IgE antibodies. A peripheral blood smear showed that our patient had anisocytosis with many microcytes and few macrocytes, poikilocytosis with teardrop cells and schistocytes, polychromatophilia and hyperchromia, and a concentration of 2 nucleated red blood cells per 1,000 white blood cells. Lab results from day 47 showed a decreased white blood cell count back below the reference range slightly to 4,900, and an increased lymphocyte count to 740, despite it still remaining far below the reference range, and a low platelet count remaining at 134,000, the same as day 44. On day 54, our patient was admitted to Massachusetts General Hospital for recurrent respiratory distress and failure to gain weight. Her physical examination showed clear lung sounds bilaterally with increased mucus production, and her vitals showed a hypoxic arterial oxygen saturation at 89%. This is while the patient was breathing room air, an axillary temperature at 97.5 degrees, a pulse of 179, and respirations of 50 to 60 breaths per minute. An arterial blood gas analysis while the patient was breathing supplemental oxygen then showed a partial pressure of oxygen at 137, a partial pressure of carbon dioxide at 46, pH of 7.39, and bicarbonate level of 28 millimoles per liter. A chest X-ray taken revealed resolution of all pulmonary abnormalities. Lab tests the day after admission showed a low white blood cell count at 3,600, which had decreased from day 47, and a low lymphocyte count at 144, which is the lowest we'd seen in our patient this far. Her platelet count had increased back into the normal range at 154,000. This table on the left over here shows the trend of our patient's lymphocyte count all the way from birth up until her admission at MGH when she was 55 days old. Even the highest levels of lymphocytes she had remained far below the lower limit of the reference range for lymphocyte count. We then performed a flow cytometry test, discovered that our patient lacked CD3, CD4, and CD8 cell surface markers, indicating that she did not have any T cells, and she also lacked CD19 cell surface markers, indicating that she lacked B cells. I would now like to introduce my colleague, student Dr. Black, who will be presenting our patient's differential diagnosis.
Thank you, student Dr. Bowd. Good afternoon, I'm student Dr. Nicolette Black, and I will be discussing the differential diagnosis for our patient. As explained, our patient had a profound lymphopenia from the beginning of life, as well as a lack of thymic shadow on X-ray, failure to thrive, and recurrent respiratory infections. This led us to suspect immune deficiency in this patient. Lack of thymic shadow is commonly seen in adults. However, when seen in pediatric patients, DeGeorge syndrome should be considered a possible diagnosis. However, this was quickly ruled out in our patient because she lacked the typical abnormalities of the face seen in DeGeorge syndrome. This led us to the differential diagnoses of intestinal lymphangiectasia, pediatric AIDS, and severe combined immunodeficiency, also known as SCID. Intestinal lymphangiectasia is also known as Waldman's disease and is a rare form of protein-losing enteropathy caused by a congenital dilation of gut lymphatics, often associated with abnormalities in the lymphatic system of the upper extremities. Blockage of lymph drainage in the intestines leads to a rupture of the lacteals and the escape of lymphocytes and immunoglobulins into the lumen of the intestine and out through feces. increasing the susceptibility of infection in these patients. Pediatric AIDS is caused by the transfer of HIV from mother to fetus, most commonly during the traumas of birth, but can also be seen in utero and during breastfeeding. This is characterized by a CD4 T helper cell lymphopenia and non-functioning immunoglobulins. Although clinical presentation of pediatric AIDS can vary depending on the amount of HIV transferred from mother to fetus and the severity of AIDS, the most commonly seen are lymphadenopathy, dermatitis, and recurrent upper respiratory tract infections. For our patient, we found it highly unlikely to have a diagnosis of AIDS due to the fact that the mother had no risk factors for HIV infection. Also, pediatric AIDS is typically seen to onset later in life at about months 3 to 6 of age. Our patient also only showed upper respiratory tract infections out of the clinical presentations previously mentioned, and most notably lacking is lymphadenopathy. We were also able to rule out intestinal lymphangiectasia because patients with this disorder are immunocompetent, so do not have the susceptibility to opportunistic infections that we saw recurrently in our patient. This led us finally to severe combined immunodeficiency. SCID is a family of genetic effects that cause immune system cells, T and B cells, to be produced abnormally. This is autosomal recessively inherited, as seen here in this diagram. There are many forms of SCID, so the mutation can be seen on many different chromosomes. The clinical presentations seen for patients with SCID are listed here. However, I would like to focus on those most significant to our patient. Recurrent severe infections of the upper respiratory tract of opportunistic nature are seen in these patients and are typically seen as an interstitial pneumonia caused by Pneumocystis jirovecii. We also see a failure to thrive, absence of a thymic shadow on X-ray as seen here, unexplained lymphopenia, and chondroosseous dysplasias. Because interstitial pneumonia is common in these patients, we were able to deduct that our patient had many interstitial pneumonias caused by Pneumocystis jirovecii. In order to diagnose an infant with SCID, they must meet two of the following three criteria: an absolute T cell count of less than 300 cells per microliter, which, as we can see in this table, our patient had less than 1 cell per microliter. T cells should also constitute less than 20% of the total lymphocytes. As seen in this table, our patients constituted less than 1%. For patients with SCID, we may also see a proliferative response to mitogens of less than 10% of a normal control. As I mentioned earlier, there are many different forms of SCID, and they can be categorized by their concentrations of B cells, T cells, and natural killer cells. As we discussed, our patient had a complete absence of T cells, which is indicative of all forms of SCID. However, our patient also had a complete lack of B cells, allowing us to rule out the first two forms. Although our patient did have natural killer cells present, and these natural killer cells actually accounted for the majority of her lymphocytes, when compared to the concentration of natural killer cells in a normal infant of her age, they were so low that they could be considered completely absent, leaving us finally with a T cell, B cell, and natural killer cell absent form of SCID. Within this form, there are two phenotypes possible: adenosine deaminase deficiency and reticular dysgenesis. Reticular dysgenesis is a rare form of SCID that is caused by a mutation on the AK2 gene, which regulates ATP in hematopoiesis, leading to abnormalities in the lymphoid and myeloid lineages. However, we would expect to see normal erythrocytes and megakaryocytes. In these patients, we expect an absence of B cells, T cells, and neutrophils. However, as seen in this table below, our patient had neutrophils present from day one, leading us to rule this out as a possible diagnosis and leading us finally to our diagnosis of SCID caused by adenosine deaminase deficiency. This form of SCID makes up 50% of the autosomal recessive patients with SCID and is caused by a mutation on the chromosome 20. Patients with this form of SCID have a more profound lymphopenia than any other form of SCID and have the unique skeletal abnormalities known as chondro-osseous dysplasias, seen in our patient as flaring of the costochondral joints and the bone-in-bone appearance of the vertebral bodies. Adenosine deaminase is used in the purine synthesis pathway to break down adenosine. When this is blocked, the concentration of adenosine in the cell rises, leading to an increase in the concentration of ATP and DATP. DATP is toxic to the cell because it inhibits ribonucleotide reductase, which is required for DNA synthesis. An increase in adenosine also increases the concentration of S-adenosyl L-homocysteine, which inhibits the methylation synthesis pathway used in B-cell maturation. These two consequences lead to the abnormalities in T cells and B cells seen in these patients. It should be noted that adenosine deaminase is utilized in all cells of the body. However, an increase in adenosine can be downregulated by 5' nucleosidase in most cells. Unfortunately, lymphocytes have a shortage of 5' nucleosidase, making them the most profoundly affected. To summarize, our final diagnosis is severe combined immunodeficiency caused by adenosine deaminase deficiency. This was further confirmed by a red blood cell assay for adenosine deaminase activity, which showed a complete absence in our patient and an increase in the levels of DATP. Patients with SCID due to adenosine deaminase deficiency will expect to see a complete loss of lymphocytes and a progressive loss of immunoglobulins. This progressive loss of immunoglobulins is due to the loss of passive immunity from the mother and the inability to replace this immunity due to ineffective B cells. Diagnosis of this disorder is emergent and, if left untreated, can be fatal. I would now like to introduce student Dr. Harry Ballar to discuss treatment, research, and implications.
Thank you, student Dr. Black. I will now be talking about the legal and ethical implications involved in our case, the alternative treatment options, and emerging research. The treatments we used were trimethoprim sulfamethoxazole, which was administered intravenously to counter a suspected P. Jarovecki infection. We also used immunoglobulin therapy with an IgG preparation. Immunoglobulins for RSV were also included to counter against that agent. Essentially, our enzyme replacement therapy was the administration of PEG-88, which is polyethylene glycol synthetic adenosine deaminase. The administration of the substance was intramuscularly twice a week, and it was guided by the levels of toxic metabolites and ADA levels. Today, the treatments have changed significantly, and we'll talk more about that later. In our patient, we conducted a mitogen study to assess immune function. Mitogen is a substance that stimulates mitosis in lymphocytes. The mitogens we used were concatenavalin A, phytohemagglutinin, both of which stimulate T cells, and pokeweed, which stimulates T cells and B cells. CPM refers to counts per minute. As you can see, the patient's values are slowly approaching the control, with phytohemagglutinin eliciting the strongest response, very close to control. We also conducted a white blood cell count. Prior to therapy, the white blood cell count was 2,300 cells per microliters, which is quite low. However, the cell counts had recovered after the PEG-88 administration. When the child was brought in for CD3 T cells, CD4 T helper cells, and CD19 B cells, the counts were below 1% a day after. However, after the administration of the enzyme replacement therapy, they had recovered significantly at 31%, 22%, and 28% for CD19 cells, well within the normal range for infants of that age. In terms of treatment today, gene therapy, which was termed confusing at the time our case occurred, has gone through significant changes, one of them being the completion of the human sequencing of the human genome, completion of that sequence, in April 14, 2003. Since then, 40 cases of SCID have been treated successfully. Immunoglobulin therapy is still in use. However, the standard of treatment now is hematopoietic cell transplant, which is transplant of bone marrow cells, and it has shown excellent outcome in 4-year follow-up. Hematopoietic stem cells can give rise to new red blood cells, white blood cells, and platelets. A study by Myers and Patel found that if the immunodeficiencies are detected very early and the treatment is administered in an ideal fashion, the survival rate can be as high as 95%. However, the success is reliant on matching HLAs. A hematopoietic stem cell is seen here in this diagram. It's a cell that can renew itself, can give rise to multiple different lymphocyte lineages, can also travel out from the bone marrow into the bloodstream, and can also undergo apoptosis. The takeaway point from this diagram is that the cell being transplanted is not one of the differentiated cells, it's one at the very start of these lineages. For HLA matching, it refers to major histocompatibility complex, which is a locus of genes on the short arm of chromosome 6. It codes for these proteins, class 1 MHC and class 2 MHC, both of which are expressed on surface proteins, which regulate immune function. Class 3 also exists, but information on that remains sparse. The critical HLA loci that are looked at are HLA-A, HLA-B, and HLA-DR. However, recently, HLA-C and HLA-DQ have also been looked at. The reason we match the HLA is to avoid any negative consequences, such as graft versus host disease or tissue graft rejection. An HLA matching flowchart might look something like this. Ideally, we would like to find a completely matched sibling donor. However, if one is unavailable, a matched unrelated donor is also acceptable. If that is unavailable, then these are the next few options. The singular double umbilical cord stem cell transplant is a very interesting one because so far HLA-C has been disregarded when matching for HLAs for these stem cells. However, a very recent study by Kay found that the disregarding of HLA-C is an independent risk factor for transplant-related mortality. So it's a very developing field. There's also many clinical trials happening. We'll talk about the most interesting ones and the ones most relevant to our case. The first clinical trial is a phase 1 study looking at an HIV-1-based lentiviral vector and seeing if that's a more safer and effective way of delivering gene transfer therapy instead of mouse retroviruses. The endpoints being measured are immune function and the level of gene transfer. The second clinical trial is an observational study looking at the long-term outcomes of patients who receive gene transfer therapy. Most relevant to our case, it's looking at patients that did not receive gene therapy and comparing them with patients who received PEG-ADA administration, which was the case in our infant. There also have been significant changes in how we diagnose for TREC, how we diagnose for SCID. Giving it away. It's TREC screening, T-cell receptor excision circles. In our case, the patient first presented with multiple infections, and then eventually an RBC assay was conducted to confirm the immunodeficiency. However, today, what's slowly becoming a standard screening procedure for newborns is to look for TRECs, which are found in developing T cells in the thymus. Normally, we expect to find 1 TREC per 10 T cells using PCR. However, SCID patients either lack TREC completely or it's expressed in very low levels. It's being used nationwide. As you can see, in purple are the states that are already screening infants right at birth for immunodeficiencies. In purple are the states that have pilots or are planning to begin screening. Green are the states that have neither pilots nor plans at this time. It's important to note that it's a sensitive, specific, and cost-effective treatment, especially in something like immunodeficiencies where earlier detection may lead to better outcomes. In terms of OMM treatments, there is not enough conclusive evidence to use SCID on a 54-day, to use OMM on an infant with SCID and a 54-day-old infant at that. There's also significant ethical considerations. About best interest standard is used for patients who are unable to communicate, and we're always unable to communicate. They're unable to provide consent, so the parents are seen as holding the patient's best interest in mind. It is assumed that they hold the best interest. They are the patient's advocates. They're directly involved with the child's care right now and will be long-term. An element of parsimonious care also comes into play, which calls on all healthcare professionals to use healthcare resources wisely and effectively. The standard of treatment today, which is bone marrow transplant, can cost anywhere from $100,000 to $300,000. However, if an HLA match is found, the survival rate is 80%. Without an HLA match, it's 70%. So the costs and benefits of that treatment need to be weighed against each other. There are also significant considerations when we talk about patient education. The parents of a SCID-born infant might receive a brochure, something like this, with resources pointed out, with different avenues for support they can approach and hopeful outcomes. Treatment aftercare is considerable because the parents need to be told that they will have to bring the infant every 3 to 4 weeks to replenish the immunoglobulins because they will be utilized. And at that point, this would have been done for the rest of the infant's life to fight against infections. That 3 to 4 week window is much longer today. A genetic counselor could also prove helpful to go through the family history and medical records of the family and identify risk factors and identify what might have caused the immunodeficiency in the first place. It's also important to tell the parents that the child should not receive any vaccinations because of the immunodeficient nature. And that does conclude our presentation. These are our references. Ultimately, we'd like to thank all the amazing faculty that were with us every step of the way and provided tremendous feedback. We couldn't have done it without you guys. I'd like to thank the audience for attending and now open the floor for questions.
Great job, you guys. We'll open it up to questions. So which side wants to go first? All righty.
Okay, the first question we got was, what is an APGAR score? The APGAR score tests 5 categories at 1 minute after birth and 5 minutes after birth. APGAR is an acronym standing for the infant's appearance, so talking about the skin color of the infant, the pulse, the infant's heart rate, grimace response, the infant's reflexes, activity, the infant's muscle tone, and respiration, the infant's breathing rate and effort. Each of these categories is rated on a scale of 0 to 2 for a total score out of 10. Any score lower than 7 is a sign that the infant needs immediate medical attention.
Okay, the second question we got was, what is meconium? Meconium is the first stool passed by a newborn, and it's this passage in utero that's been attributed to fetal response to intrauterine stress. And it's often associated with fetal hypoxia, asphyxia, and acidosis. Hypoxia causes the increased gastrointestinal peristalsis and relaxed anal sphincter tone. And transient compression of the umbilical cord or fetal head also causes a vagal response, which can result in the meconium passage. So therefore, the meconium occurs in utero due to fetal stress, such as placental complications, blood supply, and O2 decreases.
The next question we had was why PEG-ADA therapy is not working for long in about 70% of patients. My consensus was that the reason it wasn't working for 70% of the patients because the levels of PEG-ADT in patients need to be properly measured and calculated and calibrated and constantly being followed. And the PEG-AD levels may decline for patients, and they do not stay in the circulation for long because they get metabolized. So they need to be constantly replenished. And if they're not replenished, the patients who metabolize them too fast will not be able to respond to the treatment.
So the question is, what are schistocytes and what diagnosis or disorder might they be associated with? Schistocyte is a severe form of poikilocytosis, and poikilocytosis meaning the presence of abnormally shaped cells in the blood. And schistocytes specifically are fragmented red blood cells that have a jagged shape with pointy ends. And they can be found on a peripheral blood smear test, and they would be an abnormal result. And some conditions that they're associated with are hemolytic uremic syndrome, thrombotic thrombocytopenic purpura, and hemolytic anemias such as microangiopathic hemolytic anemia.
All right, another question we got was who was the boy in the bubble and how does it relate here? David Vedder was the boy in the bubble, and he was born in 1971 and he passed away in 1984. He was one of the most famous examples of S-linked severe combined immunodeficiency, which means he was completely deficient in B and T cells. It was necessary for him to live in a completely sterile environment because opportunistic infections posed a life-threatening risk to all patients with SCID, similar to our patient. And he was called the boy in the bubble because he lived for 12 years in a sterile environment that was quite literally a plastic germ-free bubble.
Okay, and our last question is, what are some causes of lymphocypemia? And what that is that the body either isn't making lymphocytes or is making it, and it's destroying it, so you have none. Bacterial infections, viral infections, fungal infections can all cause that, along with other systemic diseases such as autoimmune disorders. There can also be other causes such as malnutrition and leaking of your thoracic duct, which leads to lower lymphocytes.
All right, good job, guys. Does anybody have any comments?
I just think you guys really rocked it out of the park. And I think everybody ought to stand up and give you a standing ovation because you guys did a great job.
Yeah, I second what Dr. Dubin said. Actually, I got goosebumps part of the way through the early part of your presentation because it was so, well, there's that too, but it was phenomenal. But just one thing I wanted to clarify with the APGAR scoring, this is, Dr. Newman and I share this as a pet peeve. It has become an acronym, but it's not really an acronym. Dr. Virginia APGAR was a person. She was a pediatrician who invented the APGAR scoring in order to cause providers to look at the baby at 1 minute and 5 minutes of life. So people have made it into an acronym so they can remember the things because they don't want to just try and memorize the things. But Dr. Virginia APGAR was a person, and it's not truly an acronym. Right, Ray?
And I met her son.
He went to college with my sister.
I win.
Okay, well, great job, and we'll switch out.
No, you're not.
You have the bouncy ball?
What's up, Steady?
There we go.
Good luck, Teddy. You have that.
Mm-hmm.
Is it from like 2 weeks ago picture?
No, it's not. It's from downstairs, from the coffee shop, and I hope it's not 2 weeks old. Do my friends leave? Or who am I supposed to look at now? What the heck?
All right. Is everyone ready to begin? Yes. Sweet. Good afternoon, distinguished physicians, professors, and fellow students. My name is student Dr. Theodore Brizamidzakis, and I'll be presenting case 4 study on a 39-year-old female who was pregnant with fever after a trip to Africa. Patient history and presentation. History of present illness. So this case is centered around a 39-year-old pregnant female who presented to her OB at 14 weeks gestation. She was G1P0, which indicates that this was her first pregnancy and she had no previous births. She had a history of infertility, and she had an onset of daily fevers at 5 weeks gestation. She had a recurrent rash, and these symptoms began after a recent trip to Africa where she worked at an orphanage. 12 months prior to her initial OB evaluation, she traveled to Ethiopia. And before her trip, she received the CDC recommended vaccines, and she was also put on mefloquine as a malaria prophylaxis. After returning from Ethiopia, she had several symptoms, which included prolonged fatigue lasted 5 months, intermittent diarrhea, flatulence, and bloating. She also had a negative stool for ova and parasites, and she was on metronidazole for presumptive giardiasis. 6 months prior to her initial OB evaluation, she returned to Ethiopia where she worked at an orphanage for 6 weeks. This area was endemic for malaria, so she was also put on mefloquine during that trip. During her trip in Africa, she had several symptoms, which included episodes of diarrhea as well as a rash. 5 months prior to her initial OB evaluation, she returned from Ethiopia and she had several symptoms upon her return, which included intermittent diarrhea, and she was treated for scabies. So 8 weeks prior to her initial OB evaluation, she had her first primary care visit. She had a temperature of about 37 degrees Celsius, and beginning the week before, she had an onset of daily fevers of around 38 degrees Celsius with rigors. She had malaise, myalgia, fatigue, and her last menstrual period was 4 weeks prior. As you can see at the bottom of this PowerPoint, the gestational age of the fetus at this time was 6 weeks. And please keep track of the gestational age because it is very important to the case development. During this initial visit, she received several tests, which included an elevated eosinophil count, which is common in someone who's suffering from an allergic reaction or parasitic infection. She had the elevated liver enzymes of alkaline phosphatase, ALT and AST. This is prevalent in someone who is suffering from some sort of liver damage. And she was positive for IgG and IgM antibodies for cytomegalovirus, which is also known as CMV, and this indicates an acute infection. 8 weeks prior to her initial OB evaluation with 6 weeks of gestational age, she had her PCP follow-up visit. During this visit, she had a slight temperature, and she had a diffuse macular rash over her trunk and extremities, and she had a negative TB skin test. With 7 weeks of gestational age and at 7 weeks prior to initial OB evaluation, she had her first visit to an infectious disease specialist. During this visit, she had a history. The physician took a patient history, and she had a history of mononucleosis-like illness as an adolescent, herpes simplex vulvovaginitis, an abnormal pap smear, meningitis, and infertility. The physician also took stock of her medications, which included valacyclovir for her recurrent HSV infection, zolpidem tartrate, also known as Ambien for sleep, and ibuprofen. She had no known drug allergies. Also taken at the infectious disease specialist was her temperature, which was around 36 degrees Celsius. She had a mild conjunctival erythema and a faint maculopapular rash over her arms, hands, and torso. And she had a mildly enlarged liver. However, there was no tenderness or splenomegaly. Also taken during this visit were several lab tests. This included elevated band forms, which is seen in a ruffled border of the neutrophils, as well as immature neutrophils entering the bloodstream is an indicative of an acute infection. Atypical lymphocytes were also elevated, which have a ruffled band form, as well as an increased nucleus. She had elevated liver enzymes, as stated earlier, indicative of liver damage. She also had elevated lactate dehydrogenase levels. This is indicative of some sort of tissue or organ damage acutely. She also had elevated IgG and IgM damage, which is indicative of an acute infection. Also, other further tests included during her visit was a positive CMV hybrid load capture assay, which indicates a CMV infection at some point in her patient history, a positive varicella zoster screen, which indicates a past varicella infection, also known as chickenpox or shingles. She also received several titers for the Epstein-Barr virus, which indicates a past and not an acute infection. She was also positive for the HSV Ig enzyme immunoassay, which indicates a past infection. She also had a past infection of parvovirus, and she had a infectious mononucleosis heterophile antibody screen was negative. And this is common for someone who had a past infection of mononucleosis. At 7.4 weeks gestation and at 11.4 weeks gestation, the woman received a transvaginal ultrasound, and this was a single live fetus. During this examination, the fetus had normal intracranial anatomy and heart. There was no evidence of ventriculomegaly, calcifications, echogenic bowel, ascites, or hydrops, and there was no evidence of pleural or pericardial effusions. 3 weeks prior to her initial OB evaluation, with a gestational age of 12 weeks, she had repleted labs. As you can see, the liver enzymes sitting earlier were returning closer to normal, but not yet normal, and she had a negative cytomegalovirus viral load hypercapture assay. So at 14 weeks gestation, she had her initial OB evaluation. During this time, the patient reported that she felt well, she was on no current medications, her CMV-specific IgG assay, avidity assay was positive at 0.6, and she had a repeat ultrasound with no identifiable abnormalities. Student Dr. Nicole Caballo will be talking about the differential diagnosis.
Thank you, Student Dr. Theodore. My name is Student Dr. Nicole Caballo, and I'll present the differential diagnosis. So based on our patient's presentation, current pregnancy, recent foreign travel, and past medical history, we have at least 10 potential diagnoses. Since our patient is pregnant, has persistent fever, and a rash, we can consider parvovirus. However, she does not have the characteristic slap cheek rash on the face. Her rash is only on the body. Furthermore, she has antibodies to parvovirus and is unlikely to be reinfected. Rubella is a concern because of the high risk to the fetus, but rubella starts with a rash on the face before transferring to the body. Again, our patient does not have a rash on her face, and she has antibodies to rubella and is also unlikely to be reinfected. Rubeola has a high risk to the mother, but like rubella, it starts off with a rash on the face, and again, our patient does not have that. HIV is a high risk to both the mother and the fetus. Patients with HIV can have persistent fever, rash, gastrointestinal problems, and hepatitis. However, our patient tested negative for HIV. Her symptoms are also suggestive of mononucleosis caused by Epstein-Barr virus. She does have atypical lymphocytes. She has borderline leukocytosis, and she has elevated aminotransferase levels. However, she had a mononucleosis-like illness when she was younger. She has antibodies to Epstein-Barr virus, and her heterophile test was negative. Now, these four are based on her recent foreign travel. Malaria is prevalent in Ethiopia, but she was taking mefloquine to prevent this, and her blood smear was negative. Furthermore, she only had 4% atypical lymphocytes, and we would expect at least 10%. We can also consider intestinal parasite. After her first trip to Africa, she had diarrhea, and she was presumptively treated for giardiasis. After her second trip to Africa, she again had diarrhea, and she had a newly adopted daughter who had to be treated for intestinal parasites. When we tested the patient's stool, it was negative for ova, parasites, and pathogenic bacteria. Viral hepatitis A and B are also prevalent in Ethiopia, but our patient got vaccinated before her first trip. Her antibody tests were negative, and her hepatitis B antigen test was also negative. And while her aminotransferase levels were elevated, they were not 10 times normal, which is what we would expect with hepatitis. And while she was in Africa, she could have been exposed to improperly cooked meat and feral cats, both of which can transfer Toxoplasma gondii. But our patient tested negative for antibodies. And so after eliminating all the other potential diagnoses, we were left to investigate cytomegalovirus infection. Cytomegalovirus is a double-stranded DNA virus that's in the herpes family. It can infect the liver, the spleen, the lungs, the gastrointestinal tract, and the central nervous system. It can more specifically infect hematopoietic progenitors, monocytes, and the endothelium. And when CMV infects a cell, the cell becomes larger and usually has an intranuclear inclusion with a halo around it. So histologically, this looks like an owl's eye. We could also see cytoplasmic granules. And like other herpes viruses, CMV can become latent. CMV does this by interrupting the stable formation of MHC class I molecules or by preventing the translation of the mRNA for MHC class I. Now, healthy individuals with a CMV infection are usually asymptomatic. Immunodeficient patients, on the other hand, will present with symptoms and can have a reactivation of a latent infection. CMV can be transmitted through bodily fluids, so it can be sexually transmitted, and it can be transmitted through contaminated saliva and urine. CMV can also be vertically transmitted from the mother to the fetus via the placenta. And to test whether our patient has CMV or not, we could use a hybrid capture assay, and we could do further testing with high avidity for IgG, and this would tell us whether or not the infection is acute or reactivated. We could also test the fetus with amniocentesis and use PCR and shell vial assay. We could also evaluate the ultrasound for any abnormalities. So if our patient had been IgG negative and IgM negative, we could have just repeated the titers in the next 4 weeks. And if IgG was positive, it would be a primary infection, and negative would be no infection. However, our patient tested IgG positive and IgM positive for CMV, so we had to do further avidity testing. As time goes on, after an infection, IgG matures and can bind an antigen more strongly. So this would be high avidity. And high avidity in this case would mean that the infection was more than 4 months ago. Low avidity would indicate that the infection happened within the last 4 months and would thus be a primary maternal infection. And primary versus reactivated infection is important because of the risk to the fetus. 40% of mothers with a primary infection will transmit CMV to the fetus. Reactivation of a latent CMV infection has a lower risk, and second infection with the new CMV strain can transmit to the fetus since the mother does not have those specific antibodies to that strain. And of the 40% of mothers who transmit CMV to the fetuses, 20% of those fetuses will be symptomatic, and the frequency of symptoms range from 10% with seizures to 50% with petechiae and hepatosplenomegaly. So our patient's results was 0.6 for IgG avidity, and positive is considered to be equal to or greater than 0.6. So since our result was right on the border, we felt that the results were ambiguous. So we did further testing on the fetus. The ultrasound was actually normal. The fetus was the expected length at 18 and 21 weeks. So we did amniocentesis. PCR revealed the presence of CMV DNA. However, this is a qualitative PCR, so just the presence. We now know that quantitative PCR would have been better to determine if it were a latent or active infection. We also did shell vial culture, and that was positive for CMV, and we got the results from this within 2 to 3 days instead of 1 to 6 weeks with conventional cultures. Now, after hearing the results and considering the consequences and deliberating her choices, our patient decided to terminate the pregnancy. Termination was at 22 weeks, and we took samples from the placenta, the liver, and the lung. So this is the placenta, and the darker cells here are the lymphoplasmacytic infiltrate, which is another characteristic feature of a CMV infection. Now, if we were to stain with an antibody to CMV, we can see the infected cells, and the infected cells are the darker cells here. If we look at the fetal liver, normal cells are over here, and the basophilic or purple cells are the infected cells and are necrotic. If we increase the magnification, we now see those larger cells with the intranuclear inclusion and the halo around it, so the owl's eye, and we can also see those cytoplasmic granules. If we look at the fetal lung, we again see the large cell with the intranuclear inclusion, and so we were able to confirm that the mother had CMV and the fetus had CMV as well. And student Dr. Logan Brow will now talk about the treatments and additional considerations.
Thank you, student Dr. Cavallo. Hi, my name is student Dr. Logan Brow, and I'll be discussing treatments and additional considerations. At the time of onset, there was no clear treatment option available and no vaccine available. Prevention was and still is the gold standard. However, CMV hyperimmune globulin treatment was recommended by one of the physicians on the case based on a study published by Nigro et al. In 2005. This study, passive immunization during pregnancy for congenital cytomegalovirus infection, was broken into two groups, a prevention group and a therapy group. The prevention group consisted of 84 total test subjects, all with a primary infection and an uninfected or unknown infection status of the fetus. Of these 84 subjects, 37 were placed in a treatment group. The treatment group was given 100 units per kilogram of CMV hyperimmune globulin and demonstrated a 24% reduction in infant CMV infection. The therapy group consisted of 45 subjects, all with a primary infection and infected fetus. Of the 45 subjects, 31 were placed in a treatment group and received 200 units per kilogram of CMV hyperimmune globulin and demonstrated a 47% reduction in infant clinical manifestations. However, it is unknown if this treatment option was pursued. Current treatment for CMV infection is focused on alleviating symptoms as well as preventing recurrence in immunocompromised patients. There are currently two actions of drug on the market for CMV infection: viral DNA replication inhibitors and immunoglobulins. Viral DNA replication inhibitors act on the viral DNA replication machinery, thus preventing the proliferation of the disease. The current drugs on the market in this category are ganciclovir, cytofovir, valganciclovir, and foscarnet, all which act as either a treatment or a prophylaxis. Immunoglobulins work by increasing the immune response to CMV infection, and the current drug in use in this category is cytogam, and is used as a prophylaxis. As for clinical treatments, or clinical trials currently ongoing for CMV infection, again, we have viral DNA replication inhibitors, which consist of maribavir and valacyclovir, and the immunoglobulin being tested is cytotec. We also have an additional category of viral DNA packaging inhibitors, which work by affecting the virus's ability to insert its DNA into a viral envelope, thus making it susceptible to DNA nucleases. The current drug being tested for its efficacy as a prophylaxis is letermovir. Furthermore, we have a vaccine trial ongoing, which is looking at recombinant CMV glycoprotein B vaccine. As for OMM treatments, there are currently no OMM treatments specifically for CMV virus infection. However, a thoracic pump has been suggested to potentially increase the lymphatic flow and thus the overall immune system. However, it should be noted that there is a contraindication in pregnancy, so if this treatment option is pursued, an alternative method of the thoracic pump should be utilized. Moving on to the ethical considerations. We wish to focus on autonomy and informed consent in our case. It's important to recognize patients as individual autonomous beings. And to respect this autonomy, we must provide enough informed information to the patient for them to make their decisions based off their own beliefs and values. In our case, our patient eventually decided to terminate the pregnancy. But it's important to look at the steps that went into this decision. Our patient was originally diagnosed as infertile. So when she realized that she was pregnant, she was understandably very committed to the pregnancy. Once she was found out that she was infected with CMV, she originally stated that she did not wish to terminate the pregnancy unless there was a clear indication that the baby would be sick. Following the positive amniocentesis test, she decided to terminate the pregnancy. It is unknown what information was presented to this patient. However, we can analyze what we would have prevented had we been her healthcare providers. Our patient was infected with CMV and had a clinically manifesting form. Following the positive CMV amniocentesis test, we knew that this CMV infection was transmitted to the fetus. And CMV congenital infection occurs in about 0.5 to 1% of patients. Following the acknowledgement of this transmission, the next step was to look at the likelihood of this fetus developing a clinically manifesting form of the CMV infection. Although the data is uncertain, this likelihood was between 5 and 20%. Additionally, when we were discussing severity of clinical manifestations, it's important to note that the definition of severe differs from patient to patient. So when we were discussing symptoms, it's important to be accurate and very descriptive so that they know exactly what they are. Moving on to legal considerations. Our case happened in the state of Massachusetts, where abortion is not legal at 24 weeks or after, unless there's a severe health risk to the mother. Our patient decided to terminate the pregnancy at the 22nd week of gestation, which made this a legal abortion. However, this 24-week period is of note because it gave her a limited window in which to make her decision. As for informed consent, physicians are legally bound to provide enough information for patients to be active members in their healthcare planning as well as make informed decisions. Conclusions and recommendations for this patient. Our patient had a clinically manifesting form of CMV infection, which is generally only found in immunocompromised patients. Thus, it would be pertinent to test her for immunocompromised status. Furthermore, it would be important to offer counseling for the loss of her pregnancy, as well as counseling on transmission prevention. Patient education. There are a lot of sources out there for medical information, and it's important to point our patients in the direction of reliable ones. Two such sources that we found were familydoctor.org and cdc.gov. Furthermore, some patients prefer their information in the form of physical handouts, and two resources we found with physical handouts for CMV infection were Clinical Key and Access Medicine. Adult CMV infection is actually quite prevalent and occurs in 50 to 80% of US adults. However, clinically manifesting forms are quite rare. Due to this prevalency, it's important to preach prevention to our patients, which includes safe sex practices, hand washing, surface cleaning, transfusion testing, and universal precautions. Conclusions and recommendations for clinical practice. It's important to strive to stay up to date on information and statistics regarding our medical practice, and as well as to give this information to our patients. In regards to CMV infection, it's important to monitor for the efficacy of a CMV vaccine, as well as in utero transmission prevention studies. Furthermore, when we're preventing symptoms to patients, it's not only pertinent to present what these symptoms exactly are, but also to present the likelihood of these symptoms manifesting in any given disease. And lastly, it's important to offer CMV screening for pregnant women or women wishing to conceive. We would like to thank the KCU faculty that helped us with this presentation. Here are the members of Group 4. Here are our references. We'd like to thank you all for coming today, and I would like to open the floor for questions. Thank you.
That was a great job, really nice. I know you got some questions, so who wants to go first? Which side?
First question I got was, what is the significance of atypical lymphocytes? An atypical lymphocyte is also known as a reactive lymphocyte, and they're the result from an antigen stimulation and have therefore become quite large. The cells can vary greatly in size and shape, and they are indicative of a beta streptococcus, cytomegalovirus, Epstein-Barr virus, syphilis, toxoplasmosis, vaccination, and viral hepatitis infection.
Okay. Any questions on this side? Well, they're working on some. Okay. Let me hand this to you.
The question was, what are the effects of mefloquine? The adverse reactions to mefloquine include skin rash as the primary side effect noted. Less than 1% of patients experienced alopecia. Additionally, it can be indicated, there's an instance of vestibular disorders such as tinnitus and hearing loss. They also can have arthralgia, myalgia, muscle weakness, muscle cramps, chills, fatigue, malaise. There are some neuropsychiatric effects noted, ranging from anxiety, paranoia, and depression to hallucinations and psychotic behaviors.
Okay. Question on that side? Let's. You got to press the button on the mic, and that'll turn it on.
What are some dangers of parvovirus in a pregnant patient? Parvovirus can cause painful or swollen joints and specifically can cause a temporary halt in red blood cell formation. And this is particularly problematic in pregnant patients because this can cause transient aplastic crisis, hydrops fetalis, which can lead to rapid fetal death, congenital anemia, pure red pure red blood cell aplasia or persistent anemia. However, there do not appear to be long-term development sequelae of infection in children who do not develop hydrops fetalis. And then I had a second question of what are some effects of CMV seen in infants. And if they develop a congenital infection, they can have jaundice at birth, hepatosplenomegaly, petechial rash, small size for gestational age, thrombocytopenia, microcephaly, intracranial calcifications, and ventriculomegaly. And then there's some other less serious side effects, including hearing loss.
Okay, any others? Other questions?
I have one. The question was, is there any risk of ibuprofen toxicity in early pregnancy? Ibuprofen is considered a pregnancy risk category C, which means no studies have linked ibuprofen during pregnancy with congenital defects. There are some studies linking ibuprofen use later in the pregnancy, specifically third trimester. NSAIDs in general have been linked to problems with high blood pressure in the infant, as well as some duct problems closing in the heart.
Okay. Any others?
The question is, what is giardiasis? How do you get it, and how do you diagnose this? Giardiasis is an intestinal and/or biliary tract infection caused by the protozoal parasite Giardia lamblia. Infection is usually caused by contaminated water or food when you take in the viable cyst of the organism. And the best test would, from what I found, is typically stool samples, as you use a saline suspension or a duodenal aspirate for microscopic examination to diagnose and exclude other pathogens.
Okay. I know you guys have a class to get to at 1, so I'm going to cut it off here. You guys did a great job. And again, I'm going to ask everybody to give you guys a standing ovation, too. You really did a great job. So for people watching, thank you very much, and good job, guys.